Now we'll talk about another very important aspect of rehabilitation and a complication in the spinal cord injured patient, that is spasticity. Now, spasticity, as many of you will know, is a velocity-dependent increase in tonic stretch reflexes as a result of UMN type of injury. So there is increased stiffness of the limbs, and this increases with the each range of, means every time you are moving the limb. Unlike rigidity, where there is constant, resistance to the range of motion. So what can it can lead to? It can be a disabling thing. It can lead to disabling contractures if the patient is in a prolonged state, in the same state, or it can lead to involuntary movements also, weakness, fatigue. There can be difficulty in sleeping or painful spasms, and hygiene can be a difficult issue if the adductors are having a increased spasticity. Then initially non-pharmacologically you can go for physical therapy in the form of exercises, gentle stretching of the increased tone muscles, then joint movements. You can go for a progressive casting or serial casting, we call it. Then lastly, we also have Botox and other local motor point injections like Pinol also in the particular muscles which are affected. And surgical is the last option, wherein we go for SDR, selective dorsal rhizotomy, right? And few medicines are very commonly used. These are like baclofen, 5 mg 3 times a day. Again, for kids, the doses vary. This is the adult dose. The tizanidine we give in the dose of 2 mg per day. But just remember that any of these medicines will cause a bit of sedation, so do not prescribe this. Tell the patient that do not drive at night. Okay, that can be problematic for the patient. Or avoid any skillful activities while having these drugs. Very skillful activity, which requires adequate precision and all. Sublesional osteoporosis, because the patient is not moving his limb. Suppose he's a bedridden patient is coming to you, he will have continuous bone loss. Okay, so this can lead to falls, trivial falls, difficulty in transfers, and further increases the morbidity. What are the risk factors? Again, if the patient is an old patient and he uses steroid in some form or the other for a long time, calcium and vitamin D deficiency is addedly there, then this process becomes faster. And last, when we talk about the management, prevention is the best cure, obviously. So, in the form of calcium supplementation, adequate calcium supplementation, care during the transfers, the diet should be taken care of, and if the fractures occur, do splinting or immobilization if required surgery. So another thing is heterotrophic ossification. In this, there is an extra bone formation within the bone. So this is the formation of lamellar bone basically in soft tissue, leading to loss of joint range of motion for that particular joint. In this case, we have a knee joint here, and this is on the lateral aspect. You can feel the bone forming there. So most common affected joints are hip, knee, and shoulder and elbows. Management is avoid any range of motion if such a case has occurred, and drugs like bisphosphonate, anti-inflammatory drugs, mainly indomethacin, has proven a role. And if the bone has set in, the joint range of motion is severely affected, surgery is the only choice of option to remove that extra bone which is formed. Respiratory system, again, body deconditioning does not leave any part unaffected. So respiratory system is also affected. The volumes become less, tidal volume mainly, lung capacity decreases, ease of breathing, and ability to cough and clear secretions are compromised following a spinal cord injury. Patients usually have, in such cases, the morbidity is mainly due to pneumonia and atelectasis if not taken care of. Some cases do aspirate also. So management is by doing a good breathing exercises, and if the higher levels cervical and all are there, C1, C2 like that. So in those patients, you need a continuous physical therapy, chest physical therapy, and proper pulmonary toileting is necessary. Annual influenza vaccine and pneumococcal vaccine can also be given in such patients. And if there is any respiratory tract infection, should be taken care immediately because it can be fatal. Right? Assisted cuffing is there, and other maneuvers like if the patient can breathe in and out, he can be advised for breathing exercises. Then there can be incentive spirometry should be advised if the patient is able to do it. The different postures, if the patient is having too much of secretions, we have postural drainage techniques. Different positions are used. So not many maneuvers are there. Pressure ulcers, Pressure ulcers are another thing. So in this, what happens at the bony areas which are having a lot of pressure, because the capillary pressure is only 25 mm of interfascial pressure is only 25 millimeters, whereas what happens, the bed which we are using gives a shear force of more than 100 millimeters of more than 100 millimeters, so that obviously compresses it. And over time, if more than 2 hours, usually what we advise is a bedridden patient should be turned over constantly over 2 hours to different positions, right? If this is not done, then the pressure ulcer gradually sets in. There is different classification for that, like National Pressure Ulcer, NPUAP, National Pressure Ulcer Association of Panelists, NPUAP classification, in which we grade in different forms. So, how do you prevent it? Basically, you prevent it by using the weight transfers, proper bed positioning, change of posture every 2 hours, wheelchair setting. And also in wheelchair, do remember that every 30 minutes of wheelchair setting, the patient has to shift his weight for at least for 2 minutes, either using his both arms, he has to lift himself, or the attendant should tilt and shift the patient at least for 2 minutes for every 30 minutes of wheelchair setting. Management is by doing a regular skin checks and relieving pressure relieving methods, like using a ripple method, ripple beds, or air fluidized bed, where air and fluid both are there, because simple air bed will increase the strain, and in fact it will cause more of pressure ulcers. Adequate bladder and bowel care, appropriate assistive devices can be given so that a patient can be mobilized using a trapeze and other things. Good nutrition should be there, and always note that pressure ulcers, there is a lot of decrease in serum albumin levels. So when you're examining doing an LFT, always note the pressure serum albumin levels. If the albumin levels are low, the pressure ulcers will take a longer time to heal. So if you can correct that albumin levels by supplying adequate proteins, the pressure ulcer healing will be better. Then regular dressing is a altogether separate issue that we have to do it regularly, depending on the type of and depth of pressure ulcer. We have to do that. And on the right side, you can see different positions where which all areas you can have more pressure ulcers. Like supine position, you have this heel, sacrum, elbow, shoulder, and occipito area. Then if you lie on the side, all the bony areas which are coming in contact with the ground, like ear is coming into contact, the shoulder, olecranon process, there, the hip, the knee, and ankle. And on setting, you see the shoulder blades are being constantly having a pressure. Then again, buttocks are the sacrum part, and ball of the foot and heel, these are being having under constant pressure. Next thing which can develop in chronic spinal cord injury patients is neuropathic pain. The patients will come to you suddenly, doctor, I have developed this pins and needle sensation all over my body, or in the particular region, or in the particular dermatome. So this is affecting my life. Along with this, I'm having spasms, increased painful spasms. So this is all indications of neuropathic pain which is developing. Like, see, you can see here the patient is suffering from shooting pain, tingling, pins and needle sensation, numbness, freezing, or throbbing. All these are characteristic of neuropathic pain. Or some patients even complain of ants crawling over the feet, or the feet are on fire. So management is again by neuropathic drugs. You have the uh, SSRIs, the Roxetin, or amitriptyline like drugs, or again you have this again gabapentinoids. So many groups of drugs are there to manage those patients. Along with that, physical therapy and counseling does help in getting over it eventually. Sexual dysfunction is another one of the most neglected part of spinal cord injury rehabilitation. This is not so much common in India, but in foreign we do have a lot of discussions on sexual dysfunction, because the problems are there is decrease or loss of sensation, difficulties in achieving orgasm, difficulty in moving and positioning, lowered self-esteem and confidence. Even if he is a paraplegic, lower levels, T1 level of injury, T6 level of injury, and T8 or L1 level of injury, the patient will have difficulty in positioning himself. So lowered esteem, less self-esteem and confidence is there. In men, there may be maybe partial or complete impairment of the penile erection and ejaculation. Female menstruation may be affected. So all this leads to a toll on his daily routine activities and on his psychological profile. So do a respectful decision at the appropriate time with both the individual as well as the partner. Medical care and rehabilitation should be advised to the individual. Provision of education and information, positioning and preparation for sexual activity, birth control, prevention of STDs, everything should be given. And assisted devices for arousal or for enhanced positioning. Nowadays, there are many toys also, you can use for doing a reflexogenic erection. Okay, and treatment of erectile dysfunction if it is there by using vibratory stimulation, oral medications like sildenafil and other drugs. Then penile injections can also be given. There are vacuum devices like a simple, uh, a syringe, suppose a 10 cc syringe or 20 cc syringe that can be used. The other end, the injectable part should be cut out. That is inserted into the penis, and thus plunger is pulled out. So that will cause inflow of the blood into the veins of the corpora cavernosa, and that will also cause erection. There are other methods, like after achieving this, you can tie uh, a rubber band around the root of the penis so that can be the erection is hold for some long time. But all this has its pros and cons, and everything should be told to the patient. Then assisted fertility is another option in females.